Now let's take the information we've reviewed and put them into a clinical strategy for taking care of your patients. Here are 3 clinical settings in which ultrasound of the abdominal aorta could be performed. The first is a patient with abdominal pain and/or back pain with hypotension. The second is a stable at-risk patient with abdominal and/or back pain. And finally, you can use ultrasound in every elderly patient as a screening test, particularly those patients with vascular disease elsewhere. For management of the non-ruptured abdominal aortic aneurysm, here is a rule of thumb. If the abdominal aortic aneurysm is less than 3 centimeters, set up the patient for serial ultrasound examinations every 6 months to follow the progression of the disease. If the abdominal aortic aneurysm is greater than 4 centimeters, obtain an outpatient surgical consult to evaluate for possible surgical repair. And if the aneurysm is greater than 5 centimeters, obtain immediate surgical consultation. Obviously, when considering this diagnosis, the clinician must consider the possibility of aneurysmal rupture. Nonetheless, the diagnosis of abdominal aortic aneurysm in patients presenting with pain is formidable. The disease is notorious for masquerading as a number of other pathologies, including renal colic, diverticulitis, gastrointestinal bleeding, myocardial infarction, and musculoskeletal pain. When the abdominal aortic aneurysm leaks or ruptures, it most often results in an expanding retroperitoneal hematoma and causes great pain for the patient. This location of bleeding does give some time to salvage the patient, since the bleeding temporarily is controlled. In this CT image, we see an example of retroperitoneal bleeding from a ruptured abdominal aortic aneurysm. If the aneurysm ruptures intraperitoneal, the patient usually rapidly exsanguinates. Therefore, when the abdominal aortic aneurysm is identified, the examiner should always check Morrison's pouch for evidence of free fluid in the abdomen. If free fluid is found, then the patient must go immediately to surgery. For more information regarding free fluid in the abdomen and locating free fluid in Morrison's pouch, see Module number 11, Trauma Ultrasound.
Let's talk about how we're going to manage these patients once we've identified an abdominal aortic aneurysm. We've broken this down into 6 basic steps.
In the event of rupture of an abdominal aortic aneurysm, quick and efficient management is imperative to obtain the best possible outcome. If there is suspicion or evidence of an abdominal aortic aneurysm leaking or ruptured, immediately look for evidence of intraperitoneal bleeding by examining Morrison's pouch by ultrasound. Next, make sure to type and cross-match at least 4 units of packed red blood cells. Request at least 2 units of O-negative blood to the patient's bedside, and move the patient to the resuscitation suite of the emergency department. Make sure to prepare the patient for immediate transport to surgery and call the operating room and anesthesia to make them aware that a patient will be coming to them shortly for emergent operative repair of an abdominal aortic aneurysm. If possible, avoid intubation. There is often a drop in blood pressure after performing rapid sequence induction and intubation that the patient may not tolerate. This is thought to be caused by the effect of positive pressure ventilation decreasing venous return to the heart. This algorithm demonstrates the decision process for managing patients with abdominal aortic aneurysm. If an at-risk patient has abdominal and/or back pain, then the ultrasound should be performed looking for abdominal aortic aneurysm. If an aneurysm is found and the patient has cardiovascular instability, then the patient requires immediate surgical consultation. If a patient with abdominal and/or back pain has an aneurysm but lacks cardiovascular instability or direct evidence of bleeding, then an additional imaging study using CT should be considered to better describe the extent of the disease. If a patient has an aneurysm greater than 5 centimeters but lacks pain and cardiovascular instability, then a surgical consult should be obtained before the patient is discharged. If a patient has an abdominal aortic aneurysm less than 5 centimeters and lacks back pain and cardiovascular instability, then he or she should be followed as an outpatient with serial ultrasound exams of the aorta at regular intervals.
Now we're going to talk about aortic dissection. Typically, this tends to be a thoracic pathology, but there are cases where this can be seen in the abdominal cavity. So we'll show you some cases of that as well.
Although not as sensitive, ultrasound can also visualize abdominal aortic dissection. Risk factors for this disease include hypertension, previous cardiac valvular surgery, a history of tuberculosis or syphilis, connective tissue disorders such as Marfan syndrome, or a family history of aortic dissection. The classic symptom for aortic dissection is the sudden onset of tearing or ripping pain in the chest, abdomen, and back. Physical signs associated with aortic dissection include ischemic limbs, stroke, myocardial infarction, or ischemic bowel. There are two classification systems for aortic dissection. The older one is the DeBakey classification system. Those dissections involving both the ascending and descending aorta are referred to as type 1. Those involving only the ascending segment and arch are referred to as type 2, and those involving only the descending segment distal to the left subclavian artery are referred to as type 3. The Stanford classification system is more commonly used today. Those dissections that involve the ascending aorta and or arch, regardless of whether or not they involve the descending segment, are referred to as type A. Those dissections that only involve the descending segment of the aorta distal to the left subclavian artery are referred to as type B. This video demonstrates a longitudinal view of a dissection of the abdominal aorta. Note the dissection flap moving at the anterior aspect of the lumen of the aorta. Here is the transverse view of the abdominal aorta from the same patient as the previous slide. It is easy to see the dissection flap in the center of the aortic lumen. This slide is a dramatic video of a longitudinal view of the abdominal aorta with a large dissection. Notice how the false lumen changes in size with each pulsation of blood flow. Here is the transverse view of the abdominal aorta from the same patient as the previous slide. Again, it is easy to see the dissection flap at the center of the lumen. Treatment for dissection depends on the location of the problem. For Stanford type A, involving the ascending aorta and or arch, the risk of catastrophic complications is very high, and therefore the treatment is surgical. For Stanford type B, the risk of surgery outweighs the risk of complications, and the treatment is focused on the medical management of blood pressure and the force of contraction of the heart.
So that's the aortic pathology lecture. Now we're going to give you some final probably tips, thoughts. What do you think, Tom? How many should we give them?
Give them three.
We'll give them three. Okay, so I think the first one, and my first tip is that this is an easy study to do. It takes very little practice, and you can do this within, I don't know, a couple weeks of training.
My point, the second point, is that it's fast. When time is of the essence, and you've got somebody with a leaking abdominal aortic aneurysm, ultrasound's the test that's going to get you that diagnosis as quickly as possible.
So that leaves me with number 3, and I think I would say probably the best thing about this test is it is accurate. So there's been a lot of studies that have shown that using ultrasound to evaluate the abdominal aorta is a very accurate study, as accurate as almost any other imaging modality you can choose.